morning. Good morning, everybody. I hope I'm audible. So it's the first day of the AIOS meeting, and we are in Mumbai, and we all know that. So this course is on basically retina grand rounds, various troubleshooting issues in retina, which we face day in, day out. There are so many of them troubleshooting issues. Because retina surgery is not the same as anterior segment surgery, where the outcomes are usually well known to you, and your nerves don't get jangled, you don't kind of please. And we have Professor Pankaj Dogra, who was former head and chief of PGI Chandigarh, and now a very well-known and top-ranking retina specialist. He's also known as the father of ROP in India. We have Professor Vishali Gupta, who's known world over as a UVI and retina specialist. She has been in the international uveitis study group, also in the terminology, for the new terminology, she's all over. Main person who actually is doing a lot of international work on uveitis. So then you've got Dr. Chaitra Jaydev, whom you all know. She's doing excellent work. She's very well known for retina procedures, surgeries, imaging, and imaging is her kind of her. She's really very fond of that, and she does excellent imaging and interpretations, because imaging is not only imaging, it also is to how to interpret the image. She's going to tell us about all that, because there are juniors. I wish there was also a hybrid conference, frankly speaking, because there are many residents who don't get leave. And probably it's good to have such teaching programs for the postgraduates, because everybody can't make it to a particular place sometimes. I don't know, that's what I feel, seeing the attendance. And then we have ROP surgery by Dr. Parijat Chandra. He's Professor Parijat Chandra. He's at RP Center. He's also trained for ROP surgery, and he also considers Professor Pankaj Dogra his doyen and teacher. So he's going to tell us about the indications, when should you indicate, what kind of complication. Because this is a tricky job, doing it in prematures and also with the advanced stages of stage 4, A, B, and 5. And what kind of medical legal implications, bilateral surgeries, bilateral injections. That's one indication where you have to do bilateral surgery. Normally you don't do bilateral surgery in retina. That's what we say, but of course this is a controversial issue. So we also have, unfortunately, Dr. Rohan Chawla had his Go Air flight from Delhi in the morning, so I got a 6:30 a.m. call. He could make it. I wish he could have had somebody, but anyway, that's hard luck. Rohan tried his best. So we'll first have in the session Dr. Chaitra Jaydev. We'll have about 12 minutes each because of lack of Dr. Rohan Chawla. In case Professor Pankaj Dogra or anybody would like to speak on the surgical aspects of diabetic retinopathy, very well go ahead and speak to cover up for Dr. Rohan Chawla. Thank you so much, everybody, and I'll look forward to all of you having some interesting interaction. Please, you feel free to ask questions. We can have questions even after each speaker, because we have enough time. But of course, limited questions. Dr. Chaitra Jaydev will start the innings.
No problem. So good morning everybody, and thank you Dr. Atul Kumar for this opportunity to speak in this IC. I think it's a very well put together, which connects imaging to treatment to surgical management as well. I'll be speaking on the evolving retinal imaging techniques. I have no financial disclosures. So I'll be covering basically ultra wide field imaging, multicolor imaging and Octa. We've not seen a drastic change in the technology in the last year or so, most likely because of COVID, but I'm sure in the next year or so we'll have more to add to this armamentarium that we have in imaging for retina. So to start off with ultra wide field imaging, so this is the slit lamp image that we see with a 90 diopter lens. Which we do on the slit lamp, and then we see the indirect ophthalmoscopy with a 30-degree view, and you can see the extent which we cover. Of course, we will steer, we will focus on different areas. Then you have the regular fundus camera that we see with a 45-degree view. And then finally, wide field imaging also, what we used to have is about 100-degree. What we have is the ultra wide field imaging now, and at our institute we are using the Optos. This gives us 200-degree non-montaged view, so which means we can cover up to 80 to 85% of the retina. So in 2019, the International Wide Field Imaging Study Group published the definitions. What is the posterior pole? It is the area of the retina within the major temporal vascular arcades, and just beyond, a little beyond that. You have wide field, which is centered on the fovea and includes the retina and all the four quadrants, just posterior, including the vortex vein ampullae. And then you have the ultra wide field. Here the images show retinal anatomy anterior to the vortex vein ampullae in all the four quadrants. So these are the definitions. When we use wide field, ultra wide field, we want to know what exactly we are seeing in these imaging. So it basically describes retinal imaging into the far periphery with a single capture. We do have other traditional retinal cameras. They offer a good enough view when you're looking at the posterior pole. But then when you want to look beyond that, you need at least 4 to 9 image montages, and sometimes it's limited to the area of only the posterior pole as well. What is the advantage is that they allow increased visible retina but still require multiple images, and sometimes what happens is either very sensitive or an important data is lost when there is montaging. Whereas ultra wide field enables clinicians and researchers to document over 80% of the retina in a single capture. So this is what I was trying to tell you with respect to montaging. Sometimes it's done manually where you need to overlap the images, and sometimes there's also a feature of auto montage in several cameras. So this is how the images look when you want to look at the larger picture. So this is an ultra wide field image of the Optos, the Daytona that we're using, and you can see in a single capture you've got everything. And up till like I said, sometimes when you steer the patient's eye, you ask them to look in different direction up to the aura as well. So what are the advantages? It can be captured also through cataracts and vitreous opacities. You can see a lot more detail. Non-mydriatic, even through 2 to 3 millimeter pupils, we are able to get decent images. It's fast and comfortable and convenient to most of the patients, where you don't have to take multiple images. Multiple imaging modalities is also available in a lot of the ultra wide field. You can get FFA as well. We don't have it, but it's an amazing tool when you want to look at the entire details on angiography in a single shot. You don't miss detail as you're steering the eye or the camera. So comparison overlay for monitoring eye health is also possible. Images are available immediately for review on the screen or on an access remotely on your system. 3D wrap is also possible for patient education, and these are also included in the software itself. So other than imaging, there is also FAF. Like I said, multiple imaging modalities. You have FAF, you have FFA and ICG as well. So the ultra wide field autofluorescence captures the retina using the autofluorescence and the green light. You can visualize the RP changes very well. And these are some of the company images which show multifocal choroiditis. You can see retinitis pigmentosa, and also choroidal melanoma here visible. The entire extent can be seen on one shot. So some of the examples that we've had in retinal diseases itself, diabetic retinopathy, very, very important. We've done several studies actually where we've seen predominantly peripheral diabetic retinopathy. So this is again important because sometimes when you just see an examination, do an examination of the slit lamp at the posterior pole, you might miss a lot. And Price et al. Have compared ultra wide field scanning and determined DR at more severe levels at least in 19% of the cases, while in comparison to the standard 7 field. So this is a patient of diabetic retinopathy, as you can see, and we've managed to follow up this patient, the progression, how it began, and finally how the patient ended up. At this point of time, we had to take him up for surgery, and this is the post-op picture. So it's serial monitoring is possible, and believe me, it's the most amazing educative tool to a patient because they have no clue what the retina is. So you just show them one picture of the normal retina and show them in comparison. For sure, they are going to understand the disease and the need for follow-up and the need for treatment. Going on to other retinal vascular diseases, you can see the peripheral extent, you can prognosticate. Peripheral ischemia and neovascularization can also be detected very well using the FA feature. So these are some of the, again, the images that can explain very well to a patient to the extent of the disease. They don't seem to understand very often. And this is a patient with hypertensive choroidopathy. You can see the extensive involvement there. Now going on to inflammatory diseases of the retina, we know that it affects both the posterior pole and the periphery, and the peripheral pathologies can be very, very documented and the extent visible in a single frame. So this is the sequelae of syphilitic panuveitis showing the vasoproliferative tumor as well, and you have good tools on the system itself where you can zoom in, you can change the color from green, so you can actually highlight the the pathology very well. So this is an idiopathic retinal vasculitis. This image is pre-laser and this is post-laser. You can see the resolution of the disease itself and hence helps in follow-up. This is serpiginous-like choroiditis. So now going on to peripheral retinal degenerations, I think it's very important because a lot of refractive practice is on the high now. So you want to for sure document if there is any retinal peripheral retinal degeneration. Sometimes you want to screen these patients without dilatations because you want to make them do the scans as well. So this helps as a screening tool if you have it in your institute. You get a greater field of the image itself, and you can see multiple lesions at the same time. So you can explain to the patient as to why they need barrage laser and what is the extent of the involvement. So this is the tears that I was talking about. You can see them in one frame. This is again rhegmatogenous RD where you can see the radial slit tear. Just see that on there, you can see it. So it's easy to explain to the patient why it has occurred, because the single question that they ask is, why did my retina detach? What did I have? So this pathology, if you can show to them, they understand, okay, there's a tear, there's a hole, which is why my retina is detached. So again, to document that you have lasered, sometimes medico-legally this can help that you have managed to barrage the laser, but then this patient came to us lasered elsewhere, but you can see some lesions there below. Sometimes you may want to laser these as well, and then it's easier to explain as to why you're lasering them before the refractive surgery. So age-related macular degeneration, most often we think that it's only a posterior pole, but we are now seeing a lot of patients coming even with far peripheral involvement. So this is a patient with a peripheral PCV. You can see the extensive hemorrhage. So again here the patient has good vision, probably came in for a little for evaluation, and you can when the patient says my vision is very good but still requires treatment, it's easier to explain when you have images like this. So this is post-treatment. This is a PHCR patient. You can see, of course, there is other pathology also, but this we picked up on screening. So this is another patient with extensive, posterior pole hemorrhage, submacular hemorrhage, and we followed up this patient. Unfortunately, there was extensive scarring despite, prompt treatment. So this was on last follow-up. Blood dyscrasias, because the entire retina gets involved, response to treatment intervention can be monitored. So just a couple of patients here, immune thrombocytopenic patient. This again is another blood dyscrasia. So it's easier to explain to them and ask and emphasize the importance of systemic investigations or a referral to a hemato-oncologist. We've picked up several cases which required systemic intervention. Tumors, again, the extent, severity, response to treatment. So this is a VHL patient. You can see the multiple tumors there. There you can see some of them have been treated, and a patient again underwent. I think we managed to count 17 on lesions in this particular young patient with one-eyed patient. So this is a sphenoid ridge meningema. This was the metastasis that we picked up, and it was actually the first visit of the patient. first consultation with any specialist. So very important that we follow up these patients. And this is again a breast CA METs that you can see, you see a mass there. Angioma feeder here, feeder vessels are seen. Pediatrics, I think a lot of us do see them on day-to-day practice. Very difficult to image them, especially if they are uncooperative, to do a detailed IDO. Of course, it does not replace IDO because you need the depth perception, which you don't see on ultra wide field. But it definitely has a potential to image them and document them, which is why this was published, you know, in 2013. That was when it first started being used for pediatric cases. This is the flying baby posture that was used then to image them. This is for non-supine infants, but grown kids even at 3 and 4 years of age, because it's so fast imaging, they do cooperate for optos. So these are a couple of patients that we have imaged. This potential gyrate atrophy. This was multiple anomalies. We were not able to pin it to any particular diagnosis. So this is again another dystrophy that we saw bilateral there. So the advantages is of enhanced resolution, shorter image processing time, acquisition is very fast, very comfortable to the patient as well, ease of image duplication and manipulation because we can change the different filters, and the possibility of image transmission via electronic route is possible, and also better acquisition in eyes with cataract. We are able to see quite well. Okay, and in pediatric patients as well with very small pupils, and simultaneous imaging of the central, FA, ICG and FAF enabled. So coming to the fallacies, it's difficult to precisely measure the retinal surface area here because it's a flat image. There are many artifacts, especially lid artifacts, but with the newer devices, the California and the upgrades, I think that artifact has been taken care of. So this is pseudo color in optos, but in the other wide field you do get like Mirante etc., you do get true color as well. The cost is pretty high, but then given the value add that it can have, I think in a year or two in a high volume practice, it is quite an feasible option. So these are some of the studies that we published. So should I give me 2 minutes more because we don't have the last speaker. So I'm quickly going to cover the multicolor imaging, fundus photo versus confocal. So this is the technology, simultaneous scanning of the infrared green and blue as well is possible in this. So what we have is the spectralis which we use the multicolor for. So this is how we get the image printout. So it basically uses confocal imaging, and what the advantage that it has is you can see it in 3 different layers. The superficial, you can see the blood vessels, and then you can even see the deep RP and the choroid. So just a couple of images to show you how useful it is to see the extent of the disease, and also it helps in surgical planning. We've recently published a paper especially to see the exact extent, and we're like, I'll show you a couple of images where it's so similar to even the angiography to map the ischemia. So these are choroidal folds. This is a patient with VMT. Again, you can see beautifully the the folds. You can see the extent of the membrane. So this is the comparison between a normal fundus camera versus a confocal multicolor. You can see how the membrane actually stands out, and it's almost like 3D viewing. So ischemic maculopathy, like I was saying, if you can see the multicolor image and you compare it with the angio, you can see with a little bit of tweaking and using the different filters, the extent of the ischemia itself. So it identifies the level of the lesion, the topographical information. It has pretty good role in hazy media as well. Picks up very subtle lesions and functional information with respect to ischemia as well. So I'll just skip here. You can see the extent of the lesion. The topographical information as well you can see in the peripapillary chirpae that is seen here. And while color fundus photo is today's standard, multicolor definitely has the potential in the days to come for superior screening. It requires a long time for fixation and does have artifacts again, and undilated pupils can give rise to ghost artifacts. So in OCTA, this will be the last couple of slides. This is the transition from OCTA to OCTA, and what we use is the OptoView, and these are the different algorithms that are used in the different machines as well. So just to show you just 2 slides to show you what is the new thing in OCTA with respect to imaging is this is a patient with BR view, and you can see on the video there is a 3D rendering of the OCTA. So very beautifully you can see the vasculature that is extracted from this algorithm. So I thought that was really nice. And this is a patient with CNV. Here again, if you can see the video there, the depth of the lesion is so beautifully seen, where exactly it lies, if you can see in the video above there. But here again, the imaging is limited only to the posterior pole. It's dependent on the speed of the blood flow here, and learning curve is high. Many times we have to do it manually and many artifacts. So this I can skip, the Doppler OCT and the polarization sensitive OCT. So thank you so much, and thank you, sir, for the opportunity. If you have any questions, we'll be happy to take them.
Thank you, Chaitra, for excellent talks, and especially on the subject which all of us want to know more and more, because these are the modalities perhaps without which we can't function in today's time. With this, we move on to talk by Professor Atul Kumar. Professor Atul has been the chief of RP Center, as well as he is a Padma Shri awardee and BC Roy awardee, and one of the foremost vitreoretinal surgeon of the country, and who has done extensive work, especially in the area of macula. And that is what he's going to talk to us. And now he has set up his own AK Institute in Delhi, where he practices after superannuation. Dr. Atul Kumar, please.
Screen. Share. Okay, thanks. Thank you, sir, for your kind words. And this is a master instruction course by the Chairman Scientific Committee, number 4. So I'm going to talk about treatable macular pathologies. It will be a video-supported talk. This is a place where I work now, and I'm extremely fond of using the digital imaging system, which gives me viewing of the retina through a wide screen, flat 4K OLED screen. I use passive Polaroid glasses, and I don't look through the eyepiece because there's a camera, high definition camera over there. This camera transmits the image directly onto the OLED screen, and this has data fusion, so it's actually, I have no financial interest, but the constellation parameters are displayed on either side. I use it for every surgery, including oil removals, buckling, everything. So this is the present place where I work in Delhi. And this is just taking a video of the screen. It's not the video of the surgery through the system recorded, but it's just a video through the phone on the screen using a diabetic, very severe fibrovascular proliferation all around the disc. So such case we like to do segmentation. So you can see the screen actually magnifies the image very to a great extent. So you can go down to very high magnification levels to make sure you don't create any iatrogenic issues like breaks, or if you see a slight bleeder, you might like to cauterize it immediately. Most important thing is to find the correct plane. When this kind of high magnification in diabetics, it's very important to find the correct plane. Mild bleeding, you shouldn't bother much, but you should go and segment into small islands. This is just a small clip showing you what we do on the VR viewing system in macular surgery, as well as for any surgery which we do, whether it's peripheral retina or macular surgery. But this is a paper which has just been accepted by the Indian Journal of Ophthalmology and got the best IGO paper award. This is my resident who got the best award. And this is a 3D viewing. We got about 4 or 5 international publications now besides the IGO paper. So we just want to tell you, I just want to tell you that I got a heads up viewing. So you don't have to bend my neck onto the eyepiece. You'll see the eyepiece are horizontal, but still you got to look through and peer through a small opening in the, it's analog imaging, and it's kind of image, the magnification isn't so much. So this kind of keeps your head straight. In fact, your head's elevated. It's good for vitreoretinal surgeons especially, because for ergonomics, the back should be kept straight and your neck is straight, you feel relaxed, and it's kind of easier for long surgeries. So these are the kind of surgeries which we do. I'm very fond of myopics because I see the myopic pandemic. The COVID's going down gradually, very good efforts by the country on the COVID front, vaccines and everybody taking anti-vax groups. So when you see this myopic children, day in, day out I see children. Of course, we got to tell them to play outdoors like they do in Singapore. The small children, we also tell them to put 0.01% atropine dolls. But these Adults come with a lot of sudden distortion in vision, which could be a myopic CNV, but they also complain, get their OCT and you'll see this schisis, which is outer layer, inner layer schisis, so compound schisis. So we've done a lot of work on this intraoperative OCT as well as also on myopia, and this is one of the cases where you'll see that we're doing on the Ingenuity, the VR viewing system, the patient one eye got detached because of the myopic traction maculopathy, and developed a macular hole, which is so common in myopic traction maculopathy. This is a form of a macular pathology. So what I'm talking about macular pathology is one of the myopic macular pathologies. If you've got a LASIK patient, please get his OCT also done, just don't get his indirect done. Sometimes you harbor a myopic traction maculopathy, which can get worse with the suction you use for any kind of those LASIK terminologies. I don't know much about contour and all that stuff, but I can tell you this much, this pathology can get worse. So you might blow a hole when you do a LASIK. So many of the post-LASIK patients we find as a little traction is increased. So make sure your macula is healthy. Your readings of the cornea may be okay, but your macula may not be healthy. So a hole has developed here, and so we did the surgery and it's closed. And this is just to show you a short video clip. I use the IOCT also with it because the IOCT tells me exactly where the hole is, and also to put the flaps on the hole. But when you don't kind of center the hole, the flaps on the hole, then you will have a problem in not getting a success of surgery. So you can switch on the IOCT with it. So this is a intraoperative IOCT, which is an inbuilt IOCT. So a lot of work done from Cole Eye Institute by the people there, Rishi Singh and all that. But we've also done a lot of work, I think much more than them, I think. Since 2015, I've been using the Ingenuity device when it first came to India. So this is taking the hyaloid off. So the hyaloid is very densely adherent. It sometimes takes time. Make sure the hyaloid is off, and the best way to pick up the hyaloid is identify the hyaloid is put some triamcinolone dusting, and then you stain with brilliant blue G, and then make sure that you've got the flap on the hole. Because there's a hole there, so you got to put the ILM flaps. So you switch on the IOCT, you'll see the hole there, the holes there, and you put the flap there. And you'll see gradually, I'll quickly go on just to tell you where the hole is, and then you will make sure you do a atraumatic surgery. Again, VR viewing through a Ingenuity screen makes it easier for magnification to increase. The minute you feel that you want to catch something else besides the ILM, you better let go and restart. So make sure you got the the correct plane and surgery done that way. Now, macular holes is another thing which should be done carefully, and stage 1 holes we don't do, but stage 2, 3, 4 we do. Stage 1 and traumatic holes, sometimes you can let them be as they are, but usually the inverted ILM flap technique is still supposed to be the best. There's a lot of talk by the US group about full retinal thickness, entire retina, pick up the entire retina, cut it, diathermize it. That's very traumatic, I think. So you get myopic holes also, whether you can get holes in any patient aging, and this is a DSM, which is a dome-shaped macula over there. So this is a surgery of a macular hole which I did recently at my new center, and you can see the Ingenuity screen. This has the IOCT also with it. So the IOCT and the Ingenuity screen combined to give you a very formidable armamentarium for doing surgery, which has very high success rates. As of yet, since I've shifted, I haven't seen a single failure with my hands. So make sure that I put a little perfluorocarbon liquid also to stabilize the retina. You will say, why in a settled retina? But I still like to do it. When I pick up the ILM, I'm sure that my rest of the retina is nicely, a small bubble over there. There's no harm just putting a tiny bubble till the arcade. So this is the kind of OCT you see through this is a perfluorocarbon liquid over there. The hole you see very clearly. So this intraoperative OCT device with the Ingenuity screen, on the Ingenuity screen, you see the flap is placed very nicely. This is going all around. Make sure you pick up only the ILM and make sure you put the flap on the ILM. So less asthenopia, the epiretinal membrane peeling, we can do very good results. So optic disc pits I've done some, and at the new center, and I like to put platelet-rich plasma, which I get from a lab. So this is a surgery which is a young girl. She was about 17, 18 with very severely affected vision. You can see this kind of a CSR look, but you actually, when you do the OCT, you'll see the entire, you can see the multi-layered schisis. The multi-layered schisis is classical of on OCT is classical of a pit. So just quickly going back to the video. So this is how we see, and you should never ever peel the ileum over the hole, over the pit, because you blow holes later on post-operatively. So don't peel ileum. So only thing you can do is stuff the ileum from the side without going close to the fovea, or put platelet-rich plasma. You can see the multi-layered schisis visible over there. So what I've done here is I've actually put platelet-rich plasma on the pit, and you can do the inner layer schisis and the outer layer schisis. So you can move the IOCT guided IOCT, to see where is it, and while you're viewing the screen always. So here you can see with the soft tip cannula, I'm trying to put the little bit of platelet-rich plasma. Here I've taken off the IOC to make it more clear. You see a small air bubble which got lifted off. You see the solution which gets into the pit. The patient's done extremely well, and you can see the pre-op visual was 4/60, 624, and she's still following up. Each time we just get an OCT, and the schisis has tended to settle down. There's a lot of work by the Japanese, and they've said that it takes many weeks for it to settle down. This schisis has come down dramatically. Even the outer lamellar hole is also going down. So the patient improves slowly. Let's hope she does keep improving. This is another thing which I love doing, and I get whichever I get cases, cocktail of recombinant TPA of the concentration of 12.5 micrograms in 0.1 ml. So don't cross 550 micrograms with Avastin and the air bubble. I put a cocktail with a 41G needle. So these are the kind of cases we get. This is a case recently I got, and massive bleed. So I put a twin injection. So this was possibly a PCV case. So the PCV, pachychoroid choroidal vasculopathy, is actually a form of or a variant of ARMD, wet ARMD, which is very common in our country. Now PCV tends to develop polyps. These polyps tend to burst and cause very severe hemorrhage. So I'm just finishing in 2 seconds. So as they develop polyps, they bleed. So there's no alternative left except to inject submacular TPA. So the next 5 seconds you'll see that this is a PVD induction is a must. Before any macular surgery, please make sure you've done the PVD induction for the juniors. I'm sure everybody knows this. So the IOCT tells me that I'm not entering the sub-RP space. I'm entering the subretinal space, because wherever is a subretinal space, I'll enter there. So with the 41 gauge needle and the cocktail inside the tuberculin syringe, you can have a auto injector also, you can do manual injection. So I do a manual injection here, and you see a huge elevation which has been created. So this patient did extremely well, and this was a picture. I have the Claris wide field imaging system. It works very well. So 10 days post-op. Normally you don't need to put a long-acting bubble SF6. So these are the kind of massive bleeds you can get. So these are 2 of the cases I've done recently. So thank you very much.
Thank you very much, Dr. Atul, for showing such excellent videos of various macular pathologies which we can manage with the modern surgery so well.
Short question, or later on we can have it then, or now?
Yeah.
One question.
Yes, sir.
Wonderful videos, wonderful surgery.
Thank you.
Sir, how difficult it is for you to coordinate between the OCT images and the exact surgery when you are doing it 3D?
The hand-eye coordination works well, but there's a large learning curve. I was hearing the previous session. There is a learning curve.
Yeah.
But I think I mastered that, so I can do it.
OCT and the surgery.
Yeah,
Both.
that is easy. But more important is to learn to operate while you're looking at the screen. Because we're used to looking at everything through the eyepiece. That's a big problem. You can create a lot of trauma if you don't get used to it. Many people switch back to eyepieces.
Okay.
So getting a hand-eye coordination, or you can say screen-eye-hand coordination, is kind of a little troublesome.
Okay.
Also.
And time, how much time? Does it take more time?
No, lesser time.
Fantastic.
Thank you. now, Professor Vishali, it's okay. So we've now got Professor Mangat Dogra, who's done so much work on diabetic retinopathy and also ROP and retina. He's been a teacher all his life, and we both did our fellowships in the US. So we had a great time. We were in the US. Besides work, we also used to go out on the weekend to the harbor at Baltimore. So we had a good time learning, and so I know him very, my guru and my very close friend. So he's going to tell us about recalcitrant diabetic macular edema. How does he manage? What would be his experiences and his approach? So you would learn a lot from what he says.
Thank you very much, Dr. Atul, for your kind words. I think we have had a great association, as he said, and I am thankful that you invited me for this course. So I'll share, I do have now financial disclosure for Bayer and Allergan, because sometimes I am their speaker or a advisor. And so I think straight away I'll go on to the recent Dme classification. I think that is what is very important. There are so many classifications in the past. I think it's very important to know that these days it is center involved as shown here or non-center involved, because the whole management, the strategies depend upon that. So that's how it is mostly on, you see, OCT that you're going to have this kind of a classification. You can see the intraretinal fluid there, but it's away from the center, so this becomes non-center involving DME. So just to give you a little recap, I think whenever you get a case of diabetic macular edema, always do these investigations first. Don't rush with the treatment. And once you have done all this, blood glucose level, blood pressure, their total lipid profile, also hemoglobin, they are mostly anemic, and also doing HbA1c. And one thing which I have seen, everybody orders blood urea serum creatinine. This is the biggest mistake. This is very late, parenchymal damage. Please get their microalbuminuria, 24-hour urine protein. That is how they'll do well. And this I have seen universally. Nobody does. Everybody is happy with blood urea. That will be late. So don't do that mistake. And of course, you take fundus photo, OCT, and FFA. This is from the ophthalmology point of view. So what you want to do is send the patient to a good internist or a diabetologist or endocrinologist to achieve excellent glycemic control, normalize blood pressure, reduce the serum lipids, treat anemia and proteinuria. Everything has to be in a packet. That is what is very important. I'll show you this case here. This is way back in 2005. Just in 3 months, look at it. Just with the good metabolic control, lowering the lipids, improving the sugar levels as well as hypertension, everything, this is without laser, without any treatment. That is what you will achieve. So Dme management options, all of us we know. The main management, these are the anti-VEGF agents, which we have 3, ranibizumab, aflibercept and bevacizumab, and laser photocoagulation, which at one time, it is not gone totally. Still you may need laser in some cases later once you have done anti-VEGF. And steroids, we have a DEX implant and triamcinolone. We don't have a fluocinolone or that is not there in our country. And vitrectomy may be required in some DME cases with tractional DME. As far as the anti-VEGFs are concerned, what is very important, and we have all observed this as well as various trials have shown, that you need early intensive treatment with anti-VEGFs in the first year. I think what happens, we are happy with one injection, we don't do it. And then it becomes kind of a PR and come back. No, don't do that. Do an early treatment and intensive in first year so that in second year, number of injections would come down, as well as they'll do much better. And third year, you will have even much lesser injections. And aflibercept is the treatment of choice for patients with poorer vision. You have 6/12 or less vision. If patient can afford these days with that scheme, whatever they have, it comes to same as any other anti-VEGF. So in this kind of a scenario, if you start as a first line, they do very well. And what is very important, and that is what major topic for me, is that approximately 1/3 have persistent DME or they are refractory despite your anti-VEGF treatment, and they may require corticosteroids. So this is one paper by Sada et al. Here in post hoc analysis, which is published only recently in 2020, where they have clearly shown that 1/3 of patients experienced persistent edema during the first year after initiation of treatment. That means intensive ranibizumab treatment. And this kind of a persisted even later on from 52 to 104 months. So there are studies available like this. The study author concluded that treatment with Ozurdex is associated with a significant improvement of 4 lines in cases of DME which are recalcitrant or refractory to anti-VEGF therapy. So I'll just share you one case here. I think this lady came to me after my retirement in the new center where I work. 72 years, pseudophakic, received 9 Lucentis in one eye and 8 in other eye, also focal grid, in between had MI stenting. When she came, she was a very unhappy lady. But what she needed probably is, this is typical edema which is chronic, and you give Ozurdex. In fact, we had, I think she's still receiving Ozurdex and she's still maintaining very good vision. But at the same time, I would like to share you this patient. This patient has been with me right from the PGI. It has been 3 years from my retirement, even before that. And we used to treat him with various anti-VEGFs. And of course, on PRN basis, he was never happy. And even we treated him with 2 Ozurdex, with this very eye. And he's 660, 624 here. And this is the left eye, 624. So why I wanted to share this, that why intensive treatment sometimes is required. And maybe at this time the patient could afford, because under the scheme. So thought of giving those, they talk of 5 Eylea injection to be given monthly. And that is what I did to this patient. And this was despite that he has a suboptimal even response to Ozurdex. So you can see how it has behaved with 5 injections. And it has almost, you see, of course, some outer layer disruption is there. But look at the patient. He can now read. He's the happiest patient. He says, I'll take this injection whenever you say. So I think sometimes we do need to do this kind of a therapy where you need intensive treatment monthly. And monthly 5 injection has been now proposed in many of the trials like Apollon and other trials. So this is what finally. And then come to the DME surgery. This is especially required for the tractional DME. You may use initially anti-VEGFs here or even steroids. Sometimes they work. They may work for a longer time. Not all tractional DME may not require surgery also. But then I will share again a lady here. She used to come to me for a very long time, from 2009. She received, earlier, she won't even agree for injections. So she was receiving lasers repeated in the eye. And then finally, after even receiving so many Avastin, Lucentis, she agreed for surgery. And you can see what happens after the surgery, just with ERM peeling. No ILM peeling has been done. The vision has improved here. Not only this, you can see those old laser scars on autofluorescence, how well she has improved. So there are various kinds of refractory or recalcitrant DME where you'll have to take each case on individual basis. And that's how perhaps if you take, then you can treat them better. There are new therapies in horizon. I'm sure if they have improved, I got a message today only that FDA has improved this brolucizumab for DME. So if we don't have inflammation, this is a very potent drug. This we have seen also in some cases. We use very, very sparingly at this time. And this is longer acting. And faricimab. Also, we are looking at some of these port delivery and gene therapies. So in conclusion, I would say, since my major topic is recalcitrant DME, that 1/3 are non-responder or recalcitrant DME despite your best of management. So there you need a different approach, and you will have to treat each case differently. And you must institute good metabolic control in them. Many of them, they improve even once their renal status, other problems are there, they become better. And you require alternative therapy with steroids or prolonged monthly anti-VEGFs, as I have seen. Give them intensive treatment. In addition, vitreous surgery is required in tractional DME, which also I have shown you an example. So thank you very much for your attention.
Thank you so much, sir. Any questions for diabetic macular edema? Yes.
Sir, you said good metabolic control, but sir, I say the other way around. The diabetologists never say, go to the ophthalmologist and get your treatment done, so I don't give a credit to this metabolic control because how would you prove? You see, I mean, I do agree, metabolic control is a must. You send it to your internists, but they just don't pay much attention to that. That's what my complaint is always with the diabetologist. Second point is what you said about the macular edema, only diabetic, but it can be true for any vasculopathies where the macular edema is coming? The treatment modality, what you suggest?
Yes, for various modalities, I think these days you require more intensive therapy. What we are used to and we should not be doing is we are mostly dependent on PR and treatment, which is probably not a good strategy. At least in AMD, it is not at all good because they lose vision every time. But even in DME and even other vascular occlusion, we find if we don't institute intensive therapy, I think they don't do that well. And regarding the metabolic control, which you said, what you should do is what I have followed and we follow. We get these investigations back when the patient is coming to us. And we look again at those investigations at 3 months. That if his HbA1c was 12, 11, we want to insist that it has to come below 8. You see, that is what is important. If his lipids and other things were high, they have to come down. Protein, if there is a microalbuminuria or a proteinuria, you can't eliminate it, but it will come down. So everything you have to see yourself and then instruct and write clearly to your internist. They will do the needful. They will definitely do the needful.
Can you explain the 24-hour urine examination?
Yes, that is what is very important. Because
Can you explain what it is, why does it?
No, they just collect 24-hour urine and look for the entire protein, how much is the protein is coming there. So what we do is, we are mostly ordering for serum creatinine and blood urea. That will be very late. By that time, we have lost the battle. So please, that is very, very important. I have never seen anybody ordering for this. They all the time, please do it. You will benefit these patients much more.
Thank you.
Thank you.
Yes, one by one, please.
Yes.
Thank you, Dr. Dogra, for a wonderful talk. I just want to augment one thing. The brolucizumab, the new drug, we used it sparingly in a few cases of recalcitrant macular edema, as you've shown. And some of the cases, they really did, it worked. And we were really amazed, especially in 2 cases. They had been receiving all sorts of, even aflibercept for years, for the last few years, and 2 injections of brolucizumab brought down all the edema. So I'm waiting for real approvals and the dosage, whether it should be 4 weeks or 6 weeks. I don't know yet, but I think that might be another very good drug that we can use in the future. Thank you.
Yes, we are looking forward to that.
Just I wanted to ask you, while you are getting the metabolic control, do you start off with the anti-VEGFs? Because often these patients are having a prolonged macular edema.
Absolutely. Unless you see the sugars are way up, then you don't want to really get into trouble sometimes. But otherwise, you start with anti-VEGF therapy every month intensively, and in the meantime also gets all the parameters down, all parameters, not the sugars. We are habitual and telling just get your blood sugar all right. And they'll show you fasting mostly. And the patient may not eat in the evening, and in the morning the sugar is down. But otherwise his HbA1c will be 11 or 12. So I think that this aspect is often neglected, and this aspect also helps their other things in the body, whether it is going to be subsequently other organ nephropathy, neuropathy, or even heart involvement and other things happening.
Yeah. So another test the physicians recommend is the ACR,
Yes.
albumin creatinine ratio. That is also very helpful.
Yeah, well, that is further. But if we do simpler things, what I have listed, I think we can really guide patient, and it helps also because they have very good drugs even to reduce proteinuria, and they prescribe particular diet also, so that their proteins you can't eliminate, but you can reduce them.
Thank you.
Thank you so much, sir. Now, we'll just move on because we have some time shortage. So next we have Professor Parijat Chandra. He's going to talk about ROP surgery, indications, complications, role of anti-VEGFs, and bilateral ROP surgery.
Good morning. Thank you, Professor Atul Kumar, for making me part of this course, and it's always a pleasure to speak in front of Professor Dogra, who's already a master of ROP, and I learned a lot from him and my co-instructors as well. So I'll be talking about ROP surgery. So we understand that ROP surgery is a challenging situation, and you need an expert anesthesia team, you need an expert neonatology team to take care of the baby so that they come out of surgery safely. So how are the results of stage 4 ROP? So this is a case which you see here is having a detachment happening in the nasal retina. It's in stage 4A, and if you operate this eye, this is what it comes like at 4 weeks. So you understand that if you do a good ROP surgery, the traction will go away and the retina will attach again. So when should you operate? Let's see this case. So this case, you can see both eyes, the retina is detaching, and it's in 4A. In the right photograph, you can also see that the hemorrhage is happening there, and child was advised surgery. However, the child got sick and could not be operated, and when he came back to us 10 to 14 days later, this is what it looks like. So you see the prognosis has worsened a lot in the next 2 weeks, and now you can see that it's gone into stage 4B. The macula is also detached and dragged. So what I'm just trying to show here is that we should not delay ROP surgery. If you delay ROP surgery, the ridge will pick up more height. It will become more peripheral, more vascular, making instrument access difficult, and also making the surgery outcomes poor. And as the retina continues to rise in the center, the lens might get involved. Lens sparing surgery might not be possible, and if the macula gets involved, the visual prognosis might deteriorate. So this is not the time to refer a case for stage 4 ROP surgery, because this is all too late. It's very difficult to do lens sparing, and even if you do something, nothing much is going to come out of it. This is the time when you want to refer a case for stage 4 surgery, when the detachment has just started, you've already possibly done laser injection, something like that, and the retinas continue to progress despite treatment. Or you get a primary case where the retina is detaching, then you want to do this. So let me show you one of a few cases. So here you can see it's in zone 1, and you can see it's detaching here. So this is just to show you the surgery of this case. So it's 25G lens sparing vitrectomy, which is being done here. You can see the central TRD is there. The traction is being relieved by the cutter in this eye. And there you can see the fresh laser marks are there, given just before starting the surgery with LIO. And you can see the yellow vitreous is there. It's all gone now, and you can see the reddish glow coming after the yellow vitreous has gone, and here localized PVD is being done. And you can see the posterior pole is also not well vascularized, and this is what it comes out at 4 weeks. So again, this was a late case to operate, and this outcome might not have been possible, but it did do well. So what are the basic principles which you want to look out for? So this is just to show you a pre-op photograph. I'll show you the case after this. So basically you want to deal with this kind of central traction which is tending to pull the ridge towards the disc. You want to deal with the vertical traction which is causing a TRD and pulling it towards the lens. And you want to deal with the circumferential traction which is contracting this ridge and making it go. So this is another case which you can see now, same case which I showed you the photograph. So here now we're dealing with the central traction and removing the band which is tending to form here and trying to pull this retina towards the disc. Now the vertical traction is being dealt with so that this traction can fall back. So these are basically new vessels growing into the vitreous which are pulling the retina. So that's why they tend to bleed. And this is the circumferential retina which traction which you see there. So the vessels are now being dithermized so that they don't bleed post-operatively. And the traction has been relieved there and all around. And you can see the vertical traction is also gone. The circumferential is also gone. And this is the end of the cleanup. So another case here you can see is a heavily lasered aggressive ROP, and you can see the arrows indicate where a traction is developing and pulling this membrane over the whatever small retina is left. So in these cases we like to do 27 gauge vitrectomy because it allows us to do this without much manipulation and without much instrument bending. So you can see here the traction is being relieved. This sheet of vitreous which is pulling it towards the TRD is being removed so that this retina can fall back, and obviously you can see that the retina is already having a fold and is pulled there, and it's a very small retina because most of it has been lasered. So what do you do when you get a case like this? Here you can see that it's already lasered, is going into stage 4A, detachment is happening, and it's got extensive neovascularization. So if you do surgery in these cases alone, then again there's a high chance you'll have intraoperative bleeding, postoperative bleeding, and it will still continue to contract and progress. However, if you combine this with anti-VEGF injections, then in the same sitting, intraoperatively at the end in an air, you can inject half dose Lucentis or Avastin, whatever you want. And this is the kind of outcome which you will get only if you combine anti-VEGF with surgical intervention. Otherwise, this kind of outcomes are not possible alone with surgery. Since most of these cases come with 4A bilaterally, it becomes difficult to deal with one eye and leave the other eye alone, because the other eye might worsen and the child might be sick enough and might not be cleared for the second eye surgery. So we like to do it both eyes in the same setting, which allows timely management and allows a single exposure of GA. But obviously you have to treat it like a 2-eye procedure, so second eye has to be treated like an independent surgery. The team has to re-scrub between, we change the instrument, change the fluids, put separate post-op drops, and obviously parents have to know why you are doing this kind of procedure. What is the urgency of operating both eyes together, just in case an infection or something happens, a problem happens. So just to inform you of some common complications which newcomers might have, or even expert people might also have. So here, because the eyes are small, the instrument go and hit the retina, a small break has happened there in an attached retina. So you just go ahead and laser and you can deal with the problem. Sometimes when there's a high TRD which is there, then even instrument entry can lead to a break. So these kind of complications have to be avoided. Otherwise, the surgery becomes very difficult in these cases. Iatrogenic lens touch is a common problem which can happen because it's a very small eye and the cannula is constantly moving as you try to do vitrectomy in different parts, and the lens can be touched by the cannula. But unless it's a very big posterior tear which leads to hydration of the retina, the small indents can be left as it is without doing lensectomy, and the localized cataract stays in the periphery which needs no further intervention. This is a more alarming kind of situation which happens again because of the misdirection of the cannula, again because of the small eye. So if you take care that the cannula doesn't misdirect during surgery as you're trying to do peripheral manipulations. And even if it does happen, then nothing needs to be done. You just need to let the fluid come out through the ports and ensure that you move the cannula to another port so that the pressure is maintained inside and the fluid does come out and the eye can settle back. Obviously, post-op bleed is the most common complication which happens in these cases, as you are cutting a lot of new vessels which are going into the vitreous and doing a lot of manipulation. So never leave bleeders. I think that is the main thing. Don't leave bleeders alone and pray that they'll stop on their own. They won't stop. They'll continue to bleed once the IOP falls and the positive pressure of the VGFI goes away. So it's important to control all the bleeding before you close the surgery. Stage 4 ROP, unfortunately, is a very sad situation in our country. We get around 10 cases every week coming now to RP center, and the number is just going on increasing every year. Unfortunately, these babies are blind, but surgical results are also poor, and trial is given in the hope to get some kind of navigable vision. The recent ICROP divided stage 5 into 3 parts. Stage 5A is when the disc is visible. Most probably we leave these cases alone if you can't do anything better than this. Stage 5B are the ones we most commonly operate. Stage 5C depends. If the anterior segment is very bad, then possibly you might leave it. Otherwise, it's just like stage 5B itself. So just to show you a case how I like to do it. So this is a hybrid vitrectomy. So basically these are 23G MVRs which go in, through which 25G instruments go in. This allows for a snug fit as well as instrument maneuverability. It's a clear corneal approach. And you can see that now the papillary membranes and the sine K and the lens has been removed, and now this is a dense retrolental membrane which is there. So the idea is to remove this retrolental membrane so that you can get access to the posterior retina and then go ahead and manipulate it to release whatever is contracted behind it. So once you create an opening in the clear area of the retrolental membrane, then you can do binaural dissection, you can use scissors and forceps, you can continue with the cutter. And as you continue to dissect into the periphery, the retina will continue to fall back and the funnel will continue to open. So this is an open funnel configuration, as you can see. There's not much contraction behind, it's mostly tissues which are there. So as you continue to cut these tissues and remove these tissues, the retina keeps on opening up into the posterior part of the retina. And this is the last bit of tissue. Once you see this is gone, then you see there is the disc and there is the attached posterior pole. So these babies are basically left for blind, and basically a trial of surgery can be given, because if you are able to get something like this, then the child will be able to have some kind of thing. And you ensure a sutureless closure, air is injected in the end, and this is how it looks like at the end of surgery. So I'm not trying to say that these outcomes are very good. The outcomes are universally very poor in stage 5 ROP. What I'm just trying to say is that you can give a trial for surgery in these eyes, and if the funnel does open up and if there is a good macula sitting behind, then possibly the child will get some kind of navigable vision which will change the life, not only of the child, but of the family as a whole. Thank you so much.
Thank you very much, Dr. Parijat, for excellent surgical videos as well as showing all aspects what we need to do in cases of retinopathy of prematurity. And what has come as a boon, and you have really emphasized that if we do early lens-sparing vitrectomy, and you talked about bilateral sequential, I think that is what is very important, because these are the cases, they'll progress very fast. And if we can do timely lens-sparing vitrectomy and sequential, and we don't sort of wait till they go to stage 5, where you have already shown as a challenge, and mostly the prognosis would be poor, and you have shown beautifully so many well-managed lens-sparing vitrectomy cases, which I am sure their visual gain is very good. I think that is what we have to keep in mind.
Thank you, sir, for your expert comments, and thank you, Parijat, for that very nice talk. And now we'll move on to Professor Vishali Gupta. She'll talk to us about going on to macular choroiditis, which is another issue, when, what to suspect and management. Nobody better than her in this country. And in case we have time, she can continue with the diabetic vitreous surgery, because she has some material on her laptop, because Rohan has not been able to come. Flight was cancelled.
Thank you very much, Professor Atul, for this great honor. And it's truly very nice to see all of you in person and not sitting in the study room and, giving a good talk on the computer. The topic that Dr. Atul has given me about macular choroiditis. What we need to know about choroiditis especially is that it's a very close call between infective and non-infective. Now, I'm showing you 3 pictures in 3 rows. The first one is APM-PPE, which is idiopathic. The second one is serpiginous, which is due to tuberculosis, and third one is a placoid due to syphilis. But if you look at these fundus pictures, looking at them, sometimes you really have to look into it to differentiate infection from non-infection. So what do you do when you have a patient of choroiditis in front of you? First, see whether it is choroiditis or is the retina involved too, that is retinochoroiditis. Secondly, look if there is involvement of the optic nerve head and vessels in the periphery. Thirdly, does it fit into any entity that you are aware of? Fourth, look for associated features. Is there vitritis? Is there scleritis associated with this? A CNV? Is it a single focus, multifocal? Is it unilateral, bilateral? Any systemic disease? Look at the past records that the patients are so proudly carrying with them, and you feel irritated because it is all a chaos, but they might carry a lot of information. So is it responding the way you want it to be responding? So how do you apply it in clinical practice? That's what I'm going to show you. Now this is a fundus photograph. This lady comes to us. She's a young 29-year-old girl. And history, she says, well, she's received intravitreal triamcinolone, oral corticosteroids, anti-TB drugs, and, not much improvement. So her vision is counting finger. Now, is it choroiditis or retinochoroiditis? Here, the retina is involved, and always take the help of OCT these days to see whether retina is involved or not. Well, it's retinochoroiditis. Is there associated vitritis? Yes, there was. Patient is immunocompetent. It's a unilateral disease. Now, why would TB present as retinochoroiditis? So you know that it's probably not TB at all. Now, very important, what was the past episode like? Now, this patient was actually carrying the photo which was at home and which we got later, and this is what it was when she first presented to the ophthalmologist. Look at this picture. This is retinitis, this is unilateral, This has fuzzy borders and this has haze over it. Walks like a duck, talks like a duck, it's toxo. You don't even need any investigations. So, it's toxo, but this patient received multiple steroid injections, oral steroids, anti-TB, and that is how she ended up being like this. And of course, we did everything, and she even had toxocysts in her vitreous. But despite doing this, the vision doesn't come back because of the mess that has been created. The second is looking at the phenotype. Now, this is the phenotype which you have. Very classically, we have been taught peripapillary, finger-like, pseudopodia-like projection. Going in the centrifugal direction is serpiginous choroiditis, something that we honestly do not see very commonly. This is one of the very rare patients that we have. So this is when you see this, there is no vitritis. This is the classical variety of serpiginous choroiditis that would require steroids, immunosuppression. Though important, you may test for TB, but even if you don't, nothing major, because this is a unifocal disease and it is progressing at the tip. So the other variety of serpiginous is serpiginous-like. Now, I would give you an example of this patient, a 27-year-old male. He has choroiditis, he has vitritis, he has peripapillary involvement, but what you see is the multifocality. These are the multiple lesions, they're not unifocal, and there is associated scleritis, because I said in the beginning that you pay attention to what else is there. Now, the classical autoimmune variety of serpiginous would not have vitritis, would not be multifocal, and would not have associated scleritis. Once you have these three features in it, think of TB. So, fluorescein is very different. You can see this is ICG, of course. Lesions are hypo to hypo. And when you investigate, sure enough, Montius is positive, quantiferon is positive, some lymph nodes, and we even did EBUS through the lymph nodes, which shows TB granuloma. This is how the patient responds to anti-TB. So very important that if you are seeing serpiginous in the center, differentiate between the serpiginous and serpiginous-like, because this is TB, R infective, this is autoimmune. TB-like tends to have unilateral disease, associated inflammation, either in the anterior chamber or in the vitreous. Usually begins in the posterior pole, like this one. The classical is juxtapapillary, the first patient I showed. TB tends to be multifocal, and then there is pigmented clumping at the center of the healed lesion. Serpiginous-like can have other etiologies. Everything is not TB, so please do not say that we just treat everything with anti-TB drugs simply because we are in India. No. There can be multiple etiologies. For example, this patient actually had VZV infection treated with antiviral. Syphilis is another one which can mimic, and this is the placoid choroiditis due to syphilis. So syphilis is something that you should rule out for all the choroiditis, irrespective of its shape, size, color. So this is post-antisyphilitic treatment. Then comes the multifocal type of choroiditis. So far I have spoken about diffuse choroiditis. The multifocal choroiditis itself can again be confusing. For example, this 57-year-old monoocular woman had trauma in the opposite eye, and you see some of these choroiditis patches, fluorescein, disc edema, some hyper somewhere. Peripapillary, I thought there could be a peripapillary membrane. There was disc edema, vitritis. So for want of anything else, we made a diagnosis of sympathetic ophthalmia because the tests were negative. So treated her with steroids, immunosuppression, initial response, and then worsening. So that was my point number 7, that if the patient is not responding the way you want the patient to respond, please look for alternate etiologies. Now this patient, if it was sympathetic, it should have responded to what we were giving. But if there is worsening, then what it is, repeat the test, repeat whatever it needs. Harmontius was positive, quantiferon was positive, and we even went to the extent of enucleating the blind eye, which showed a single AFB sitting there. So it was actually TB presenting as multifocal choroiditis, where the initial tests were negative, but on receiving immunosuppression and steroid, the test became positive. So it's always a good idea to repeat the test after 3 months or 4 months if things are not going the way you wanted them to go. So this is how she responded. This is the algorithm, that is the nutshell. Choroiditis, when it presents, it could be diffuse or it could be multifocal. If it is diffuse, see whether it is retinochoroiditis or serpiginous. If it is retinochoroiditis, there are two possibilities. It could be toxo, the example that I showed, or it could be viral. On OCT, toxo would always have underlying choroidal involvement. That will be retinochoroiditis, viral will be purely retinal. It could be serpiginous, which can be autoimmune or which could be infective, and I have already highlighted the difference, how to differentiate the two. If it is autoimmune, you may investigate if there is no response to steroids, but you can actually start steroids. If it is infective variety, always investigate to rule out infectious etiologies, TB, viral, syphilis, before you actually initiate therapy. It could be multifocal, which could have a very classical phenotype. I haven't touched this point because of the time shortage, but PIC, MUDES, AMPI, very, very classical. Just start whatever you want to do. But atypical phenotype, like my patient with sympathetic ophthalmia had atypical phenotype. So always, always investigate before you treat. Thank you very much for the very kind opportunity, Professor Atul. Once again, a sheer pleasure to be present in person.
And we have 10 more minutes for your diabetic vitreous
So
surgery.
I can give the diabetic, okay. Well, now switching gears from uveitis to diabetes, and I will give a talk which originally Rohan was supposed to give. My talk may not be actually complete, but anyways, I would just share what it is. We have young people sitting in the hall who would be doing or planning to do vitrectomies for diabetics. Before you take up the patient to OR, it's very important to have preoperative considerations, which includes good metabolic control. Professor Dogra highlighted that. Give preoperative anti-VEGF agent because it will help in reducing the intraoperative bleed, but always make sure that when you are injecting as a pre-op measure, everything is under control. It's not that you have injected, planned surgery, and then your anesthetist or somebody says BP is very high. Because if you are postponing the surgery after injection, the chances of development of a hole and combined RD would be very high. Pre-op PRP is another important thing. Wherever retina you are seeing in the periphery, please get a PRP. And if you are doing PRP and there is a traction, just stay away from the traction. Don't go too close to it. The key point in the whole diabetic surgery is just single, you identify the right plane. Rest all is a cakewalk, I must say. Choose a good machine and choose the cutter that allows you to work very close to retina. And we do have now bevel cutter 10,000. Honestly, 10,000 you don't really need most of the times, but up to 7,000 cutter, especially when you are working close to the retina. Now, this is one such example. In diabetics, of course, like any other surgery, you would do a core vitrectomy, make a good clear vitreous has to be done. Now this is the point. You want to enter the membranes at a point where it is away from the retina. And once you have the membranes, you just keep on insinuating. Here I'm using proportional reflux because I use that a lot, just to use and separate these membranes from the underlying vitreous and underlying retina. As you keep on separating, keep on cutting them, and then go to the next segment. Now, you can see here the patient is not bleeding much, and that is mainly because of the preoperative anti-VEGF and the laser scars that you may be seeing. As mentioned previously, Dr. Atul showed a beautiful video. It's important that you segment. You put them into multiple segments and then you can keep on peeling. For want of time, I will not go into the full, but you can see the pre and post. The third point, which is very important, is intraoperative control of bleeding. Unlike some other surgeries like vasculitic and all, where you can have the control of the bleeding even if you attend it later, diabetics are something different. This was just to show how you can use proportional reflux. But this video is just showing you that in diabetes, if you see a bleeder, it's better to tackle it there and then, because if you leave it for it to come back to later, you may have a fibrin, and fibrin acts as a glue. Now you can see here, there was a bleeder here which has been diathermized with beveled cutter. You can actually, you don't have to use a second instrument at all. I don't remember using second instrument, for most of my cases. You can use it for most of the things. You can go close to the retina, do the aspiration, take out this blood which is on the surface of the retina, and if you're a beginner, do the proportional reflux, displace this blood from the surface of the retina, and then just take it out. The identification of vitreous cases is the key step. Now this video I will just show you that you have done a good dissection, and you can see here a thick membrane which was dissected using a cutter, and there is a break here underneath it which you will see soon once the this thing is just below. This was a break, it's a combined RD, this is the break. So you have dissected the membranes nicely, and you think, well, I'm an experienced surgeon, I did a good surgery, so there may not be anything left behind, because honestly it doesn't show. So this is another node here which was taken care of. As you can see, we have taken care of, and by this time the retina looks fairly stable, as if you have removed everything from the surface of the retina. And then you inject then you inject Kenacort, which is very important, because many times these cases may not be visible to the naked eye. So I use either MIOCT or a Kenacort, of course we all use. So use Kenacort and see this whole sheet of posterior schisis which was left behind. So this is one of the very important tips which has been said multiple times, but is worth repeating, not to miss schisis in diabetic patient. And the fourth one is MIOCT. Dr. Atul again showed beautiful microscope integrated OCT. You can use it to identify nodes. You can use it to make sure that there is a complete removal of the vitreous, especially if you are not in a mood to put Kenacort for whatever reason. So you can see here that after the clearing of the vitreous, we are using proportional reflux, which is basically used to create planes. And this is MIOCT guided. You have a node. You can see where your instrument is actually going and what is the distance between the retina and the node. So it can, it can guide you, but to be very honest with you, you can do surgery without MIOCT as well. If it's there, good. If it's not there, it's okay. And of course, you can detect the area of strong adhesions, and this one here shows a very nice vitreous schisis. You can see this is the schisis here. The vitreous is actually split into 2 layers, and when you are using OCT along with your intraoperatively, you can remove that schisis, and you can actually see, ensure that that schisis is removed, because you don't have to inject. Now here you can see this is the splitting of the vitreous in 2 layers, and you will see that towards the end you can cut it and you can actually do OCT again to see the retina is all. I think I'm running, this is the post-op to show that all that has been cut. And the 5th and the last one is that bimanual dissection always resort to whenever you are requiring it, because the bimanual dissection also, I will show you a short clip here. I don't think this is required. Now this is the kind of the cases where you would need bimanual dissection, because the retina is really very firmly adherent. Put MLS, and I generally use forceps, and I use my cutter still with proportional reflux to, with the other hand, to separate these dense adhesions from the underlying retina. Now this is what it is. Once you have this plane and you have entered the right plane, the rest becomes easy. And you can of course use OCT, but to be very honest with you, when retina is really lifted and detached, focusing the OCT is not easy. Many a times you are seeing it clinically and then you ask your fellow to focus it because you want to show it to a meeting, but at times it does help as well. And 6th is, do we have time or I'm done? 6th is for doing that plane, change the direction, shift to a side, because this is a video taken in between the surgery. I have removed all this and I was planning to go, but it's not comfortable. So come to this side, create a new opening through which you are comfortable and start working from that direction, because one particular direction peeling from here was not working, but when I entered from here, you can see the fibrovascular proliferation could easily be separated, and you can do the segmentation and carry on the surgery as before. So I think we have only 5 minutes left. So the video is running, that's fine, but I just wanted to make some points, and if there are any questions, I would be very happy to take for both the talks. And thank you very much, sir, once again.
Any questions for Professor Vishali Gupta for a very nice 2 talks which he gave, or for any other presentation if you have? So thankful to all the teaching faculty who've worked hard and they've spared their valuable time to come and speak here. So really, I'm very appreciative of all this effort which they've made, and your audience, very important. They've come far distances, and now coming to metropolis like Mumbai, Delhi and all, it's not so easy because you got to find accommodation, travel, all that stuff. So they've made that effort, and I'm sure this may have been a good teaching, a learning experience for them also. So thank you all once again. We've finished well in time, and I thank all the speakers for having kept to their time, and thank you very much.